Hi, everybody. Thank you very much for the invitation. I'm Dr. Amrauwi Sana, specialized in electrophysiology at the American Hospital of Paris, and I'm very happy to join you today. So we're going to speak about the radio frequency ablation of atrial fibrillation in heart failure patients. So atrial fibrillation is the most common arrhythmia in the world. In 1 in 4 adults age 40 and over developed AF during their lifetime, and almost 8 in 10 adults with AF or atrial flutter are over 65 years old. So that's the very common arrhythmia in the world. Here we can see the global map of AF in the world, most in United States and Canada, West Europe, but also in Asia and South America. So this is an ECG in atrial fibrillation here compared to sinus rhythm here. We can see that we have a normal rhythm, regular and 73 beats per minute. Here in AF, quite rapid and irregular. So what are the factors that contribute to atrial fibrillation? So we can have obesity, alcohol, cardiovascular diseases, the stress also, caffeine, the level of activity, but also some pathologies which are really common. That's why we have this arrhythmia, which is really common with heart failure, high blood pressure, history of infarction, coronary artery disease, and also sleeping apnea disease and diabetes. So what are the main symptoms of atrial fibrillation? So we can have asymptomatic patients, and that's the problem, because we can have patients with AF complications because they didn't have the treatment without diagnosis, but we can have also patients with symptoms like palpitations, fatigue, shortness of breath, and also the reduction of ability to exercise. So why do we have to diagnose and treat AF? Because there is a risk of death, which is increased, more than threefold increase in patients with AF, a risk of stroke. 30% of all ischemic stroke are due to AF. Also a risk of LV dysfunction with heart failure, and almost 20 to 30% of AF patients has or they are treated for heart failure due to AF. Also, we can have cognitive decline, depression, so psychiatric complication and impaired quality of life, with the risk, of course, of hospitalization due to heart failure mostly. So why do we have to treat and to diagnose first and treat AF? In order to introduce the treatment, in order to avoid a stroke, heart failure, and the increased risk of morbidity and mortality. So what does the guideline say? So the guideline since 2020 says that we can propose in grade 1 recommendation in patients with heart failure, so LV dysfunction, and treatment by catheter ablation. So what kinds of ablation do we have to propose? So first, it's intervention with pulmonary vein isolation, and then depending on the center or on the map during the procedure, we can perform additional ablation. Why should we perform AF ablation in heart failure patients? First of all, because we have several studies like this one, Castle AF from Roche and Old, showing that with catheter ablation in heart failure patient with atrial fibrillation, there is a decreased risk of mortality, cardiovascular mortality, and heart failure admission, so hospitalization in patients who underwent this kind of treatment compared to the conventional treatment. Also, there are several studies showing that there is a need for early rhythm control, so early treatment compared to more delayed treatment. So what kind of ablation can we perform? So first we have, and it is recommended to do pulmonary vein isolation. And then we can target, it depends on the different groups, so we can target lines in order to isolate, you know, the wall of the left atrium if there are a lot of rotors or areas of low voltage. So it depends on the different group. So this is an example of a lab with the Abbott system, with the Untitled system. And before every ablation, so we try to do a CT scan in order to do the reconstruction, the 3D reconstruction of the heart, especially the left atrium. Then we do a punction of the femoral vein, so in the groin, putting our catheter inside the right atrium. Then we will do the function, the transeptal function, in order to go to the left atrium. So this is the catheter with the Abbott Insight X system. When we put our catheter, so this is the decapolaire sinus catheter. So we can put our catheter without any fluoro. Then our other catheter, so we can see here that we have the CS catheter here, and here is the grid catheter, so the new catheter from the Abbott, with the Abbott system, with the reconstruction of the left atrium. So we can see here that we are reconstructing, you know, the anatomy of the left atrium with the veins. We can see here the left atrium. So while we are doing this, we have the anatomy, but we can also record with this system all the EGMs from inside, so the electrical map from inside, with high resolution, allowing us to have all the direction of the spins of the region of arrhythmia inside the left atrium, with a lot of precision with this new catheter compared to here with the old system. So here, this is an example of a patient with atrial fibrillation, persistent atrial fibrillation and heart failure. We have performed the pulmonary vein isolation, and we're trying to do the posterior box with the line here. And while we are doing the ablation, we can see that in real time, we can see the different orientation of the spine, showing us that we are doing a blockage, a line here with good precision. So here, this is the case of a patient with atrial fibrillation, persistent atrial fibrillation, and we can see with the analysis of the electrical map of the left atrium that we can have a leak here with zone of blockage here, and we know that we will come with our catheter to complete here and to stop this area of leak, electrical leak here. So this is a patient, 72 years old. It was performed with another system. He had AF, continuous AF since 60 months, with shortness of breath. It was a stat 3 NHA. Very severe symptoms. He wasn't able to walk, to have a normal life, and he had previously AF ablation in another center with only PVI ablation. So with the map, we can see in red the zones of low voltage, and in black the zones of low voltage and zone that can be associated to like rotors. So I have performed in this patient a box. I have completed the pulmonary vein, and then it was converted to atrial flutter from the left atrium. So we can see here that it was coming here. So this is, yeah, we can see here the place of slow conduction. So we can see here the atrial tachycardia, atrial filter, which was organized. So I had to come here with the catheter in the slow conduction part, and we can see here, so still atrial attack and then sinus rhythm. So this patient was performed in like 8 months ago. I have seen him like 1 week ago, and he's still in sinus rhythm, walking, and very happy. Thank you very much for everything, and I'm waiting all to answer to all your questions.